academia, so the professors like yourself, our talented researchers and students, together with our corporate partners, to explore co-innovation opportunities. We don't miss out our startups as well. So that's the idea of Innovation Access Program. I run the Future Health vertical of that. And so that's why you guys are here. We are here to talk about how to take this industry forward, how to potentially collaborate and come up with new and better solutions for our future. So that's one of the reasons why we partner with Biotechin.asia, who also have the same goal of fostering collaboration across different members of this ecosystem. So without further ado, I'll pass it on to Lakshmi, and you can introduce Dr. Suvanto, who was gracious enough to come and talk to us about her wonderful research. Please, Lakshmi, talk it.
Okay. Good evening to one and all present here, and very, very warm welcome to one and all present here. Those who came really, really early, I sincerely apologize for the delay. I think it's a rush hour traffic and everyone is trying to reach here on time. Sorry for the delay, and welcome to you, ma'am, once again. And I'm Lakshmi here, and I am the co-founder and managing editor of Biotechin.asia, and I'm extremely happy to be the compere for the day today, not only because we have an excellent speaker like Dr. Suvanto here, but also because this has been a dream project for us, to organize a talk called Confluence Point Diabetes. So this will be the inaugural talk of our series of talks called Confluence Point. And the word confluence signifies, it comes from a Latin word, and it signifies the meeting of numerous streams of thought to create a powerful force. So like that, it has been a strong contention for a long time that, to manage a multifaceted chronic disease like diabetes, or for that matter, any disease, we need people from all streams to work together. We don't need only industry or academia or startup. All of them need to be collaborating and make things happen, especially in order to develop innovative solutions for diseases like diabetes. Today we have an excellent audience here. We have data scientists here, and we have clinicians here, doctors here, we have startups. So as we all know, the topic of today's discussion is diabetes, and we all know how it can affect everyone's quality of life, and it can lead to a lot of complications like stroke and kidney complications. So recently all of us are speaking about this war on diabetes, which the Singapore's NUHS has been declaring. So populations across the globe, they are facing rapid rates of diabetes, and the numbers are climbing. So management of it primarily involves prevention, screening, diagnosis and therapy. So these are the three main pillars of any disease. And then we are going to start this inaugural talk with Dr. Suvanto, speaking about changing the course of diabetes from molecules to men to the population. So this will be followed by a series of talks by other professionals. Even tomorrow you can be a speaker here. So the aim is we all discuss about what are the implications of the disease and how we can help each other and together further the understanding about this disease. So let me give you a brief introduction about our speaker. So Dr. Suvanto is the director of the National University Health System Regional Health System Planning and Development Office. She's a senior consultant endocrinologist at NUHS. She's the assistant professor at NUS School of Medicine, and she's the director of Singapore Population Health Improvement Center. And she's also an assistant professor, adjunct assistant professor at the Perelman School of Medicine, University of Pennsylvania, USA. So she has an extremely long profile, which you all can read online, but then there are some really commendable achievements which I would like to point out to you. She's on the advisory boards of several biotech, pharmaceutical and life science industry firms, and she's a recipient of national and international awards, including American Heart Association Awards, Singapore's National Medical Research Council Clinician Scientist Award, and she was awarded the 2015 Public Service Gold Award. And she has been a speaker at various thought forums throughout. And today she is here to speak about two very important clinical trials which she has been a part of, which is the Bright Spot study and APT2D study. And by explaining about this, she is trying to tell us how we can change the course of diabetes for improved outcomes at the individual and health system level. So before, without any further ado, I would like to invite Dr. Sue Ann Tho to come and deliver her speech, and a huge round of applause for her.
Well, first of all, thank you very much, Lakshmi, and to the organizers, including NUS Enterprise, for having me here today. I understand this is the very first one, so there's probably a lot of pressure to make it worth your time. I have given a couple of talks of the same title, and the nice thing about having this title is that it's so broad that I can pretty much talk about anything. So I assure you, if you've seen or been to one of my other talks of the same title, that the content won't be the same. Okay. I just have a quick show of hands. Who are the scientists among you? Do you all work? I know I met some of you who do work in diabetes. Who hasn't worked in diabetes at all but is just interested in diabetes? Okay, great. Okay, that helps me a little bit figure out what level to pitch it at and how much detail to go into. So then I'll start with what is diabetes and why is it that we are even at war, and why has Singapore declared war on diabetes. And then I'm going to highlight a couple of examples of, for the scientists' benefit, basic science research and how that contributes to fundamental knowledge that could help us in this war, as well as human physiology studies, because what happens in cells, in mice, in animals may or may not be relevant in humans. And then share with you how in our research journey as well, we still do some of all the things I mentioned, but we're also moving more and more into deeply phenotyped cohorts in the population. And then I'll end off with an example of how I think our journey always takes us where the data is leading us, and now I think where the needs are as well. We are now looking at certain interventions that are data-driven to help guide more targeted action that we hope can be more effective. Okay, so that's the overview. So I'd like to credit my team, I think, for coming up with this slide. This slide really explains what insulin does and how it functions when you do not have type 2 diabetes in the normal situation. So in a normal situation, after we eat, food gets broken down, and it's in simplest form, gets broken down into sugars or glucose. And we need that because our cells, particularly muscle, need to use that as substrates for energy, right? So that's why we eat. We need to grow, we need to get energy, we need to thrive. So after we eat, these sugars, signified by the lollipops, need to be able to get into the cell, right? But unfortunately, they can't just open the door on their own. They need help from the keys, which is insulin. So after we eat and our sugars start rising, the pancreas, which is an organ that sits right here, will start making insulin, which is a hormone that helps drive the glucose into cells, okay, particularly skeletal muscle, right? So that's symbolized by the key. So that's in a normal situation. Keys are there, sugar comes out, opens the door, sugars can go in, do its job, muscles happy, everybody's happy, right? Now in a normal person then, after you eat, your blood sugars never go dangerously high. They're always kept within normal range, around 4 to 8 millimoles per liter. Now in other countries, other units may be used, milligrams per deciliter, whatever it is, it should be either within 4 to 8 millimoles per liter or 70 to 140 milligrams per deciliter in a normal person. So what happens when you begin to be at risk or start progressing towards developing type 2 diabetes? Well, what happens is that you've probably heard of the term insulin resistance. So meaning the tissues, the cells that are supposed to respond to insulin somehow become more resistant to the actions of insulin. So that's analogous to now all the sugars, the lollipops coming, the glucose trying to get into the cell, but unfortunately the door is shut very, very tight and it's very resistant. So what happens is that the pancreas says, okay, I guess I gotta make more keys. Now this key doesn't work, gotta try another key. Now instead of one key, open the door and sugar gets in, you may need to try 2 key, 3 key, 4 key, 5 key. And that resistance, how tight that door is typically also associated with weight gain and obesity. Okay, so typically the more obese or overweight one gets, the door becomes tighter and tighter and more resistant to the typical keys that have to come in. And the pancreas initially will work hard and make more keys and is able to do that. And that's why you may have heard of the term pre-diabetes, the stage that precedes the development of type 2 diabetes. And all that is that if I told you that normally our body can regulate our blood sugars and keep it within normal range, and when you have diabetes, it's abnormally high, there's a stage in between where it's higher than normal, but not so high that you have full-blown diabetes. And so it is thought that during that phase, this is what's happening. You still can produce a lot of keys, and it's not normal, but your sugars aren't super high because you still got the keys to try and drive them in, okay? So when diabetes sets in, actually the pancreas has tried so hard to keep making more keys, it's run out of keys, and it can't make enough keys anymore. And when that happens, then the blood sugars will go extremely high, okay? So in full-blown type 2 diabetes, people are taught to have lost at least 50% of the pancreatic function, have lost at least 50% of their ability to make those keys and make insulin. So then the blood sugar levels can go dangerously high. So in type 2 diabetes, there's two fundamental problems here: insulin resistance, i.e. the door being so tight, and insulin secretion becomes impaired, or there's beta cell dysfunction. The beta cell is the cell in the pancreas that makes insulin. So those two things happen together when one has type 2 diabetes. Okay, you're with me so far? Okay. So in the spectrum then, you have healthy, you have pre-diabetes, diabetes, and then why is it that diabetes can cause so many problems? Diabetes in itself can be a very silent disease, you probably are aware. When your blood sugars are high, you may have very non-specific symptoms, or you may not even be aware of it. And even if you're aware of it, you probably don't see any major ill consequences from it. The problem is that if your sugars continue to be uncontrollably high for a more prolonged period of time, that high sugar levels in the bloodstream can start damaging the blood vessels. And when they start damaging the small blood vessels, you have problems with the eye, what we call retinopathy, ultimately potentially leading to blindness. Amputations occur because the blood vessels of the legs can become affected, and also the small nerves of the feet can become affected. And when it's affected, you may not be able to feel so well. So when you have an injury, you may not even be aware. And then because there's an injury and there's impaired blood flow to that area, it can't heal so well. So it's a double whammy. In fact, it's even more complicated than that, because when your sugars are very high, it's also thought that our immune system cannot respond as well. And so all these things in combination becomes a recipe for disaster. And that's why, unfortunately, people who have prolonged high blood sugars with all these end organ damage can suffer from ultimately amputations. Okay? If they damage another small blood vessel in the kidney, that leads to progressive renal or kidney failure, and potentially even end stage, you will need dialysis. Heart failure and stroke happens when it damages the bigger blood vessels in the brain and in the heart. So it sounds very grim, but the good news is that with effective blood sugar control, no one with diabetes should have any ill effects, should have any of these complications. And I would argue that, I find the work that we do so meaningful because we are in an era where I really see absolutely no good reason why anybody should have to end up with these complications. Why? Because we know and understand so much more. If one needs medications, there's so many more options that can be tailored to their needs. Are there gaps? Certainly, and we will go through some of that today. So why is it a problem? Why are we needing to declare war? Well, it's a huge problem, not just in Singapore, but globally. Okay, we know that the prevalence of diabetes has been increasing even prior to 2010. But at the rate we're going, by 2030, 8.3% worldwide in 2010 will go 9.9% in 2030 worldwide. This translates into this 550 million people with diabetes, and it's thought that at least 1 in 2 of these people don't even know that they have diabetes because it can be very silent. Now, ultimately, of course, if it ends up with those complications, then it's not just the individual, but at a societal level, because remember, it's also the indirect costs that comes from loss of productivity, the impact not just on the individual, but the workforce and the families. So there are major societal costs and implications from diabetes and its complications. So why did I decide to even venture into diabetes? I mean, when I was a younger doctor, youngish doctor, I remember being told, why do you want to study diabetes? You just have to look at smelly feet all day. Isn't that terrible? That's so depressing. To be frank, I was never planning to go into this specialty, but this was one reason, this patient was one reason why I became attracted to the field of diabetes. This was actually in Boston when I did a rotation at Harvard Medical School, and she was a 28-year-old woman, type 2, not type 1 diabetes, type 2 diabetes. And she was coming in with her 3rd heart attack, and she's already had 2, fortunately, minor strokes. So she's still functionally okay, but 3rd heart attack. And I was just shocked, sad, but also just really, restless. Why is it that someone who's not that much older than me, I mean, I'm familiar with relatives or friends who are older having all these problems, but a 28-year-old, like someone just like you, that was just very difficult for me to understand. And so I became fascinated by what were the mechanisms that underlie this, right? And I won't bore you with all the details because today we only have about 45 minutes, and I promised you that I would select different parts to share about. But essentially, there are very complex interactions between all the various organs and tissues, liver, fat, cardiovascular, the vessels, etc. So at different stages of my career, I've been working at these different parts of the pathway, but it's always driven by issues, unanswered questions, and challenges that we see in our patients. So then I came back to Singapore again. I mean, I was first here during SARS, 2002 to 2004, working in a hospital there, and then I left for the United States. So this patient, though, I met before I came back to Singapore in 2002. And then I went back, I came back in 2000, this time I was already an endocrinologist. And people here, obviously, I mean, I grew up in this part of the world, but they look entirely different from the patient that we saw. So one would think, so not a problem, right? So what's the big deal? That was isolated to the United States. But guess what? Our Prime Minister just not too long ago said that this is a very serious problem. And I think he said, it's precisely because you're not worried that we're really worried. And why is it then that we've had to declare war on diabetes? Well, if you look at the numbers, the statistics, you'd say, well, we don't have that obesity. Why is it a problem? Well, globally, 2015, 1 in 11 have diabetes. In Singapore, we've already beaten that figure. We're at 1 in 9 in 2014. It's probably even a little higher now. By 2040, it's anticipated worldwide 1 in 10. We're already in 1 in 9, and we keep going like this. 1 in 5 are going to have diabetes. That means you look to your left, look to your right, there's a very good chance your neighbor or yourself will have diabetes. What's worse, as we get older and we can't help that, over the age of 60, 1 in 3 will have diabetes. And our risk may not be uniform. We know that in the Chinese, approximately 2.5 in 10. In the Malays, 5 in 10, 1 in 2 people. And in Indians, 6 in 10, more than 1 in 2 people. So you might say, why is that? Some of the scientists who work in the field of GWAS and genetics will say, it's the genes. Well, I think diabetes being such a complex disease, and type 2 diabetes in particular, is a polygenic disease. So I don't think it's all the genes for sure. It's very complex. It's probably not just the genes. There is obviously environmental factors, including physical activity, food choices, perhaps even cultural, social, behavioral differences that may underlie what we see to be differences in underlying risks for developing type 2 diabetes. So there is a very strong unmet need still for diabetes treatment, and I'll argue particularly in Asia. The numbers are staggering, and India and China are going to top the world, if not already. One-size-fits-all approach to treatment is really not good enough. Okay, we have a lot of studies from Western and Caucasian populations. We have some coming out of Asia, but much more in Caucasian Western, and we cannot extrapolate necessarily what the findings are from those studies onto our population. Secondly, we need to understand the trajectories. I would argue, even though I specialize in diabetes, that diabetes, so what? It's the end point that matters. It's all the complications I talked about, because if you're well controlled and you just have diabetes, you're fine. You can have a very good quality of life and you do just fine. What's the problem, right? So why is it that some people can progress from normal pre-diabetes, diabetes so quickly, and then their control may not be perfect, not bad, and they progress to all the complications so rapidly? So the slopes of those graphs are very different. Some people, their control is not perfect, not horrible, but they are still able to hang out without complications for a longer period of time. Don't get me wrong, no matter what, if your sugars are uncontrollably high, it definitely will lead to complications, right? But the point is still, not everybody's the same. Life doesn't seem to be fair, we know that. And different people progress at very different rates. So I would argue that even though diabetes is what I do, who cares? If I could pick them up a lot sooner, and I can predict which ones are the ones that will end up with the kidney or the heart or the eye complications, that's what we care about. Can we be more targeted about what we do to prevent that from happening? And that's really the mindset that we are adopting in a lot of our research. So is there indeed an Asian diabetes phenotype? For those of you who work in science, I think this has been a strategic angle that Singapore has been trying to leverage on to say, oh, everything Asian diabetes, but everything, oh, Asian heart disease, Asian everything, that's how we sell Singapore. I think that's not good enough. I think there has to be some basis for that, and oftentimes they are, but we have to be, I think, clear about hopefully what is different and what's similar. And the reality is we don't yet have conclusive evidence for each of this, which is why we have a lot of work to do. Okay? But these are some of the characteristics that are thought to be possibly different in Asians. One is we've heard that we can develop diabetes and its complications at much seemingly lower levels of BMI, right? So lower levels of obesity, at least as crudely measured by BMI, and everyone knows what BMI is, right? Body mass index. Okay, but there's thought to be a greater amount of the bad fat, putting fat in the wrong place, in the visceral, inside the organs, and the liver, and to an extent also inside the muscle. There's thought also to be, I told you that two things need to happen when you have diabetes. The door needs to be tight, the insulin resistance, and the keys are not made. There's thought to be more of a problem with the keys not being made because we're not that obese, so presumably our door is not so tight. But we don't really have conclusive evidence for that notion so far as well. There are some small studies here and there, but then there are also some small studies that show the opposite. And you'll see from some of the data that we share today that I think some of the work that we're doing hopefully will provide more definitive evidence for what's really going on in our population. There's also thought to be higher inflammatory markers because it triggers a whole cascade of things, and like I said, it's naive to think sugar is the center of the world. There's very complex, different pathways, including inflammation, that ultimately leads to all those complications that I talked about. And then, well, you might say, but this is the 21st century, so the whole world's affected by it. Why us? Why Asia? I think it's, my view is that part of it is the rapidity of urbanization, and Singapore in particular. We've gone from third world to pretty much first world in 50 years. So that transition has occurred so quickly that our biology probably hasn't had time to adapt appropriately, and it's probably hit us even harder. The complications, there are also certain features. In Asians, there's thought to be higher risk for heart disease and heart failure at younger ages. Stroke and amputations and peripheral vascular disease are also higher in this part of the world. Kidney disease as well, and certain types of cancer, such as liver cancer in particular. And that may be because there's also a lot more fatty liver and also viral hepatitis in this part of the world. So there may be a multiple hit situation going on, particularly in Asia. So at the same BMI of 23, if you look at Europeans and then different Asian populations, Japanese, Chinese, Indians, Asians definitely have a higher prevalence for the same BMI. And even amongst Asians, there appears to be potentially some differences, and it's highest in the Asian Indians. So, this is Asia's big problem, and what is causing it? Well, there are several different possible explanations, okay? And I emphasize again, a complex problem, usually never one answer. But one plausible explanation is that we have adipose tissue dysfunction. Adipose tissue is a fancy word for fat, okay? So is fat good? Is fat bad? We always used to think, well, you gain weight, you get fat, fat is bad, right? But actually, if you look at some of the data, as I've shown you, you've got people of the same BMI, exactly the same BMI, but this person has 21.2% body fat, this person has 9.1% body fat. So Asians can hide their fat very, very well, but we also seem to put it in the wrong place. So if you look here, fat can accumulate near the skin. That's what we call subcutaneous fat. Okay, so all that cellulite and all that you think is horrible, actually from a metabolic standpoint, probably not so bad. Okay, but it's when the fat goes inside your organs, near the internal organs, in the liver, that is thought to be worse. So simplistically, the fat that's in the skin is thought to be good fat, and the fat inside is thought to be bad fat. So not all fat is the same, and that's what we mean by fat function or adipose tissue function. And I just shared with you that my research is always driven by observations that seem to be unanswered. And I shared with you earlier that vivid photographs of real patients that I've encountered and what are some of the similarities and differences that we've observed. So again, life is not fair, and I use this visual to explain the concept of fat storage capacity or adipose tissue capacity. And there are others that we collaborate with as well, such as Tony Vidal, who's a professor in Cambridge that we worked with for many years, who have written very elegant reviews about this concept. And the concept essentially is that if you have good adipose tissue capacity, actually that's good, that's healthy. So if you can eat and eat and eat and store your fat away in the right place, near the skin, you may not like how you look, maybe, but you may not run into as much problems as someone who, after they eat and eat and eat, it doesn't go to fat in the skin, but fat inside the internal organs and in the liver. And we also have different set points. So not just where we put it, but the set points. And again, life is not fair. So that's analogous to us having different cup sizes. And if you imagine the teapot pouring tea inside your cup, that's equivalent to excess nutrients if you overeat and overeat and overeat. What happens? If you move your cup quickly and you empty it out, you can still keep healthy. But if you don't move and you keep pouring, it's going to overflow, right? So unfortunately, some people have smaller cup sizes than other people. So I'd say simplistically, perhaps Asians just have smaller cup sizes. We cannot afford to allow so much to come in before we already run into problems. And so I think this, I hope, drives home illustratively the point that this concept of adipose tissue capacity is one that has some basis, and although seemingly initially counterintuitive, can make a lot of sense, right? So when I came back to Singapore, one of the earliest research projects and grants that I wrote up and got funded for was called Fit Fat, Families with inherited traits for functional adipose tissue. And we were basically interested to try and tease out some of these observations and hypotheses that we had, whether or not indeed different people have different ability to have functional fat. So we recruited families, and it's thought that if you have a first-degree relative of type 2 diabetes, you're at higher risk. So we recruited people with a first-degree relative versus those who didn't. We did scans, MRI, MRSs, to look at fat partitioning, where they put their fat. And then we also, these were young men between 21 to 40 years old. We worked with an excellent hand surgeon who did small excision biopsies from the thigh, and we biopsied simultaneously fat and muscle tissue, and also cultured them in the lab. And we looked to see what the function of their tissue and cells actually look like. So fat function can be thought of in a number of ways, and this is one schematic that roughly highlights some of the key features of fat function. When you have positive excuse me, energy balance, so when you're eating more than you actually need, then you need to be able to store it away in the subcutaneous, that's SC, adipose tissue, right? But if you can't, and it is impaired, it can't expand anymore, then you have deposition of fat in ectopic, extra locations that's not desirable. Then what happens is that the fat cells, this is what your fat cells actually look like under a microscope, will grow bigger and bigger, and then they need blood supply. They need to be nourished as well. But because it's expanding so quickly in size, it may not be getting enough. That's what hypoxia means, lack of oxygen in your fat cells. And that evokes a number of different stress pathways, autophagy, and inflammation then can ensue. And this whole gamut leads to adipose tissue dysfunction. And there are several different genes, proteins, different candidates that all have been implicated in each of these processes. And we now know that fat, previously thought to be just a very passive storage organ, too much, it just goes there. Now we know that that's not true. It's a very active endocrine organ, and that means that it's capable of making hormones as well. Thank you very much. And we know now that it can secrete more than 600 bioactive substances. So we really need to better understand what these substances do, what their targets are, and what's their relevance clinically. So how do we go about teasing this out? So the approach that we've taken in our research program is that we do work with people who are excellent in basic science, mouse model work, and there is definitely value in that. Humans are very complicated, you cannot control them, and you know, if you're scientists, that if you want to tease out causation, you need to control for variables, otherwise it's too complex, you can't figure out what's happening, what's going on, which is causing what. So I think mouse models, cellular models obviously play a very important role in our scientific discovery and expansion of our understanding. But there can be limitations because obviously mice are not humans, and there's numerous examples of how what we found in mice don't pan out in humans. So when I came back to Singapore, I realized that even though I've worked with mice models and I understand some of these things, there's no point me building another mice lab or core facility or anything like that, because we've got excellent scientists in Singapore who can do that. We probably have less people who can work with humans and work with human cell lines. So we focus most of our efforts doing this. So we do, like I explained to you, fit-fat is one example where we are very clear what is the question that we have, and then what might help us answer the question. And we recruit individuals into these cohorts where we then characterize them very carefully with, I'll explain to you in a minute what these clamps and things are, okay? But then we do imaging, we give them meal challenges, glucose tolerance tests, etc. So we know what their metabolic responses are. And in some of these cohorts also, we do these little biopsies that we manage to get fat and muscle, and we harvest them and we culture them as cell lines, right? So that way, if we wanted to examine, remember that pathway I showed you with all those different things, we do have the potential then to knock down or overexpress a certain gene or protein and ask what effect does that have on certain aspects of fat metabolism or muscle metabolism. And indeed, that's what we do. Okay, so this is Madhur. Madhur was a PhD student in our lab. He's since graduated and he's now working in Boston University. So Madhur spent his PhD working out adipose tissue function in the fit fat cohort and another related cohort. So we said, you know what? We've got all these fat cell lines from people in our cohort. And then there's another human cell line that's very widely used in the field. It's called SGBS. It stands for Simpson-Golabi-Bamel syndrome. And it was isolated from a child with an overgrowth syndrome. Now, when we take these fat or muscle and we culture them as cell lines, we've shown, like many other labs have, and that's good, that what we have shown is not unique to us. We've shown that these cell lines retain the characteristics of the individuals that they were derived from. So in other words, if you are someone who's on the spectrum, more insulin resistant, compared to someone who's on the other end of the spectrum, more insulin sensitive, when we look at certain genes and proteins in the insulin signaling pathway, we see from the pattern of the expression of these proteins, we can tell who is insulin resistant and who is insulin sensitive. Now, this doesn't go on indefinitely because obviously with multiple passages of the cells, they begin to poop out. So there's a limitation in that we can't keep going for multiple passages. But we've shown that up to passage 12, for the most part, it still works pretty well. Now, the SGBS has the advantage, for whatever reason, because it was from a child with an overgrowth syndrome, it behaves a little bit like an immortalized cell line. You can keep going and going and going, and it still retains its characteristics. So it's valuable in that sense because it's an almost infinite resource, right? So we wanted to compare the primary human cell lines that we have against this other human cell line to see if there are similarities or differences, so that when we want to ask downstream questions, we know which one we want to use. So that was the first step. And basically, we did a very comprehensive comparative study between the primary human white adipocytes that we harvested from individuals in Singapore, that we took the fat cells from, as well as compared to this fat cell line from this child with the overgrowth syndrome that many labs in the world are all using. And we showed that yes, there are many similarities, but there are also some differences. And in fact, the SGBS cell line behaves more like a beige cell line, or brown, has a capacity to become a beige or brown fat, more beige, which means that it, in the field of fat, another concept is that when you have browning or beiging, there's more mitochondria, so it's able to use more energy. Okay, and so that is also very attractive as a potential mechanism or approach to help people lose weight, because it burns more energy, and potentially also be helpful for things like diabetes. Okay, but so we found that the SGBS has more capacity to do that than most of our other regular human cell lines. So understanding that, then we know which model we want to use for different things. And then he then went on to look at two specific proteins that have been implicated in GWAS studies to be associated, in this case for FIT2, with type 2 diabetes, and FTO for obesity. And so he would overexpress or knock it down and try to tease out what effect that actually has on the fat cell. So this work is now in its final stages of revision and resubmission for publication. So hopefully we'll be able to share. So maybe next time you come, even though the talk is the same title, the data that you hear about might be a bit different. Okay, so that's an example of how we can go really deep into cells and molecular biology at a molecular level, and you can see how if we find something significant and meaningful, it can have implications for hopefully therapeutic targets, and it can at least also expand our understanding of what fat cells actually do, right? Another example I told you about browning is a collaboration that we had with Scott Summers' lab when he was at Duke NUS. And Scott basically showed in mouse models that a certain lipid species, ceramide, was essentially bad, and that if you have cold or beta-androgenic agonists, it can reduce this unhealthy lipid species in fat, and that when you stop making so much of this unhealthy lipid, you can induce beiging, and that the effects on adipose are unique and autonomous, cell autonomous, is very specific to fat. And we also showed or provided him with data that showed that these species of lipids is indeed higher in obese states as compared to people who are lean, and they correlate very well with insulin resistance as well. So you can see this is an example of how the mouse and the human findings can be very complementary and help build a case for what might actually be going on. So I told you earlier that one size fits all, definitely not good enough. So what are the key questions? I covered some of this. I said what determines progression of type 2 diabetes and its complications. Why is it that different people have different susceptibility and trajectories for developing diabetes and its complications? And what's the role of the non-sugar factors for developing these complications? What determines response to treatment? And how does the understanding of all this help us with developing more novel biomarkers as well as therapeutics? And then we can potentially stratify groups of patients for mass customization. Oftentimes people think personalized medicine is very expensive. I don't think we necessarily need to be personalized to one person. I think there are groups of people that are more similar, and actually it doesn't necessarily have to be necessarily very expensive, right? So as you can see, we got a bit restless. Yes, we work with the fat cells and we work with the small cohorts, but those were not going to help us answer all of these questions. So what did we do next? We said, well, this is really lacking, and there are a lot of different studies sometimes that we get approached to consider doing, and they say, oh, do you have patients like this? Do you have patients like that? And we didn't really have a good database to be able to figure out, do we or do we not? Where are they? What's happening? We didn't. Okay. So we set up originally a very simple concept, biobank and registry for stratification and targeted interventions in the spectrum of type 2 diabetes. And I told you that it can be a spectrum. Remember that funnel I showed you? From normal to pre-diabetes, and even if you have diabetes, you can be without complications or with complications. Okay. So what we did was that the team, in collaboration with the School of Public Health, recruited patients from our hospital with type 2 diabetes. And because they are patients of our hospital, and we obviously in the study we would consent them, etc., to get information from their medical records as to whether or not they have complications. But better yet, we didn't want to just assume that everything in the records was correct and or everyone would be at the same level in terms of having all these different tests done. So at the point of entry into this biobank registry, we ran the same labs for everybody. And these are labs that every diabetic should have once a year anyway, to screen for any kidney complications, to look for the cholesterol, and so on. Okay, so we would pay as part of the study for them to have these annual labs done one time to enter the registry. So everybody was kind of happy because the patients would have this done, which they would otherwise typically pay for. The doctors were kind of happy because there were people who were helping to make sure that these labs were done if the patient's interested, and they can view the results just like any other test that was typically ordered. So within 6 months, we had about 300 people enrolled into this registry. We also said that other than the type 2 diabetics, we want to enroll those who are at risk. Why? Because if we really want to understand progression, we can't just look at one end, right? You gotta also go further upstream and plot further upstream to understand where it begins. And once someone already has diabetes, they would be on medications, etc. So it can also cloud the picture. And we wanted to then recruit people who are at risk. So at-risk groups would include gestational diabetes. We knew that there was already very good work happening in that space, so there was no need to start again, and we would just collaborate with the Upsing and team. And then another group would be those who are obese. Okay, so we do still have them, although smaller numbers, in Singapore, and we have bariatric surgeons who do bariatric surgery, and we work with them, and we would recruit a small cohort of these individuals as well. The other group are those who have first-degree relatives with type 2 diabetes. So we know that if you have a family member, first-degree relative means father, mother, brother, sister, then you are at least twice as likely to get diabetes. So we said if you have a family member, our patients, if you have a family member 30 and above who don't have diabetes but would like to know if they might or might not have it, they can also participate in this. And if you have more than 2 people, we will send the team out even on a Saturday morning to draw blood and enroll into this registry. So that's how we kind of started. The aims were very simple at the beginning, just to develop a registry that can help give us some baseline information that can guide the design and serve as a resource for future studies and trials. And the second was that we knew that we can't do everything and do so many things on everybody. It sometimes is unnecessary, doesn't make sense, would be prohibitively expensive, and we never believe in doing things that don't make sense, right? So if we're going to do something, we should be clear about what we're going to do. Will we learn something meaningful? And it should always do no harm to the participant, and do we stand to learn something meaningful for society and for the person? So we knew that we had the capabilities to go a lot deeper, and I'll show you in a minute some of the capabilities that we have, but we didn't necessarily do that in everybody from the get-go. And the third aim was to validate non-glycemic markers, so things that are not related to sugars, that may also be contributing to the complications. So these were the different elements that we have capabilities to do within the platform. For the registry, so everyone that comes in, this one everybody has because it's a questionnaire and it's about 55 pages, and this is with the scope of public health, so we kind of minimally adapted it with them. And so everyone would have these information that may or may not be always actually routinely collected in clinical practice, because as you can see, there's a lot of information, right? Then in some people, we may do these physiology tests, be it glucose tolerance or mixed meal tolerance tests, the clamps, the frequently sampled intravenous glucose tolerance tests. I'll tell you a little bit more about what these actually assess. And then we have the ability also to do imaging and some other parameters. So for example, if you've got a lot of beige fat, right, if that really exists, then you might have higher resting energy expenditure. And then we also biobank some samples so that in future we may look at immune pathways, immune cells, oxidative stress pathways, and tissues for gene and protein that may be of interest down the road. Okay. So this was the entire platform. Not everyone had everything done. But I think our thinking was that we want to be strategic about it, where, for example, in the fit fat cohort, we take the extremes, top 10, bottom 10, we know who's who, and then those people we recall for the full Rolls Royce or full suite of things, because they have very interesting phenotypes that we want to tease out better. Right? Okay, so not satisfied with that, we realized, as I told you, that by the time you get here and here, you're already halfway through the war, and it's much harder to win the war, right? We need to look at earlier stages, and so we figured that we need to try and think about what we can do in the pre-diabetic population, because at least the diabetics, they were already within our health system with electronic medical records. We can at least passively follow them. But the first-degree relatives that came in, once we enrolled them, we can tell them where they are, but then after that, what? They may be normal, or they may be pre-diabetic, and they may or may not require a doctor follow-up, and certainly not hospital to follow up. So what happens to them? And I think there's also very important things that we can learn from them, and for that individual also, I mean, now you found something in me, then what? Like, what am I supposed to do, and how do I know if I will progress, right? So this was where we then expanded the non-diabetics within Brightspot, and that's what APT2D or AP2D is about. So it's called Assessing Progression to Type 2 Diabetes. And so in this, we're taking the non-diabetics, and this time we're not limiting it to the first-degree relatives only. We're taking anyone. So if anyone here is above 30 years old and less than 70, I don't think any of you will be more than 70, and then you're interested, you may be eligible as well. And we have a target of 1,500 pre-diabetics and 800 people who have normal glucose tolerance. You may say, how do I know? Well, if you take part, if you're interested, we will help you figure it out. So we will help do the glucose tolerance test, and that from that test you can tell whether you're normal or you're pre-diabetic. We have found in some instances that people are diabetic and they didn't know about it as well. About 5% of the people that step forward actually fall in that category. Now, if that happens, we give you, actually for everyone, we give them all their results, and if they are not normal, we counsel them about it. They get given booklet information and regular set of care, but then we refer you on to a provider of your choice to follow up, right? So there are no drugs, nothing that we are testing. It's just monitoring over time to better understand the factors. So we talked about those slopes, those graphs. We want to understand who are those that can hang out, who are those that progress, what are they doing differently or the same? Is there something biologically different about them? Show you those statistics, the Chinese, the Indians, and Malay. Why is it different? Is it genes? Is it something else? Hopefully, the study will shed some light on why that's the case. So, after we figure out who is normal and pre-diabetic, then you come in for these tests, and I told you I'll explain to you what these two tests are, but they essentially measure insulin secretion, so how many Ks you're able to make, and insulin resistance or sensitivity, how tight your door really is. And these two tests are the gold standard tests in the field, but they are not done routinely, clinically, because they are very laborious, they're pretty intensive, they require pretty specialized skill sets to perform. They require infusion of sugar water and insulin, so things that your body would normally make, but you just gotta know how to do it, and then what to make of those results. And it's incredibly expensive. So this is not something that's done in routine clinical practice, but certainly in the field, it's well validated measurements of insulin sensitivity and insulin secretion. So after that, every 6 months, people come back for their glucose tolerance tests. And so if they were to convert, if they were normal and they switched to pre-diabetic, we would know. If they were pre-diabetic and they got better, we would know. If they were pre-diabetic and they progressed to diabetes, we would also know. Okay, so every 6 months, we repeat it. And then at the end, 3 years, so we will follow them for 3 years. Or if someone converts to type 2 diabetes already, then we bring them back for the test that measures the insulin secretion and the insulin sensitivity again. So how do we do this? So the clamp tells us insulin sensitivity. So it tells us how tight that door is. How does it work? Well, we would infuse the same number of keys in everybody. So everyone gets the same amount of insulin. Okay? Why? Because our liver makes some sugar all the time. And the amount of sugar that somebody may make from the liver may differ also from person to person. So we have to then give everybody the same amount of keys and insulin to shut down first what the liver would normally make, to take care of that. Then we infuse back sugar to maintain your sugar levels in a normal range, okay, of 100 milligrams per deciliter. So, and then we monitor it very frequently, and this procedure goes on for 3 hours, okay? And so if you're someone who's very insulin sensitive, so usually someone who's very fit, very muscular, whatever, and their cells and their muscles are able to take it up very effectively, they only need 1 key, open door, very quickly. They need a ton of sugar to go in, because remember, we've given everybody the same number of keys, right? So someone who's very insulin sensitive will need a lot of glucose to keep the glucose levels at the same level in everyone of 100 milligrams per deciliter. Whereas if someone is very insulin resistant and potentially on their way to becoming pre-diabetic or diabetic, then they would require very little glucose from us to keep the sugar level at 100. Okay? So that's how we tell whether you're insulin sensitive or insulin resistant. And as you can imagine, our body will regulate, and so you can see that's what's happening. And then there are a period where it's steady state. So this period of steady state is where we can tell how much glucose you're actually needing to keep your body circulating glucose levels at 100, and that's what we call the M value. So just remember that, because I'll show you data related to the M value. And so a higher M value means you need more glucose, you're more insulin sensitive. A lower M value means you're more insulin resistant and you need less glucose. Then the next procedure is the frequently sampled intravenous glucose tolerance test. And in this test, we give everybody the same amount of glucose through the veins. And then we are measuring how much insulin you're able to make in response to that standardized glucose load. Okay? So we're literally measuring how many keys are being produced in real time over 10 minutes. Right? So that tells us the ability of your pancreas to make insulin. Okay? So I explained to you earlier that the paradigm as we currently think we know it is that when you develop prediabetes, your glucose will start to climb, right? Already. But then your insulin production will go up to compensate because your insulin resistance is already climbed and high. And so your insulin production will go up to try and keep your glucose levels down. Then when you develop full-blown diabetes, the insulin production starts to drop dramatically, right? So it is thought that in pre-diabetics, you have high insulin resistance, but also high insulin secretion to compensate for this. So is this seen in our population? So that was our first question. We started this study, we launched it at the end of April last year. Our first patient who had the visit, participant, because no one's sick really, so yeah, participants, who came in for the two tests I mentioned was at the end of August. And we then analyzed the first few hundred who completed that visit. So there are a lot more findings to come from this entire effort because we haven't even begun to look at the longitudinal data. We haven't even finished recruiting everybody. We are now at about 1,000, what's the latest, 1,100? 1,200. Okay, so we are 1,200 out of 2,300. So we're just over halfway. So it will be very interesting to see whether our data still holds true. But even for the first few hundred that have come true, we're finding some really interesting, potentially game-changing things for diabetes, at least in our population. So a lot of words here, but essentially what we meant to say in this slide is what I've already told you about, that APT2D was an expansion of the non-diabetics from Bright Spot, but this time we also included others, not just the first-degree relatives that come from other health screening efforts in the community, and that overall we hope to establish a resource that can help discover and validate biomarkers that relate to how well we can make insulin, the function of our beta cells, as well as insulin resistance in all spectrums of type 2 diabetes development. And one might hypothesize that, like I told you about those different graphs, that actually our population may be quite heterogeneous and there may be differing pathophysiology, progression, and outcomes ultimately in different people with those different slopes. So what have we found so far? So this is data from the first few hundred who completed the CLAMS and the FSI-GGT. So we had 235 normal people and 189 pre-diabetics, almost equally distributed across both sexes. And this was a ethnic distribution. We saw more Chinese than Malays and Indians. The mean age was 45.6 in the normals, and the pre-diabetics were older. Not surprising, because age in itself is a risk factor for development of diabetes. And they were a bit heavier, again, not surprising, right? We know that it doesn't mean that just because we're skinny overall, doesn't mean that the impact of gaining weight and obesity is any different. In fact, it's even more pronounced in our population. We just can't afford to get fat, right? Percentage body fat also a little bit higher, and by definition, of course, the glucose levels would be higher in the pre-diabetics. So interestingly, because we know diabetes is associated with all the other risk factors for developing heart disease and strokes, like high cholesterol and high blood pressure, they all tend to go together. We didn't find any statistically significant differences, though, between the normals and pre-diabetics that we've looked at so far. There's perhaps a signal towards a higher blood pressure in the pre-diabetics, which would not be surprising again. So what did the CLAMS and the FSI-GGT tell us? The insulin sensitivity measures, remember the M value? We said, of course, we expect it to be lower in the pre-diabetics, but to be honest, this delta, this difference, is so puny. Compared to Caucasian and Western population data, you'd expect a much bigger gap between the normals and the pre-diabetics. Okay, so yes, the pre-diabetics are more insulin resistant, and because we've got decent numbers, statistically we appreciate that difference. So indeed there's a difference as we would expect, but the magnitude of that difference is not what we would have expected. It seems relatively small compared to what we know from other studies that have come out in other parts of the world. What about the insulin response? Well, this is dramatically lower actually in the pre-diabetics as compared to the normals. So we are not actually seeing that compensation happen in our pre-diabetics here. So what does this mean? Well, there's something called the disposition index, and that is a product of the M value, the insulin resistance, and the insulin secretion. Because if you are still able to make insulin, one might expect that your disposition index, the product of the two, would be no different between the normals and the pre-diabetics when you're able to compensate. But actually we see it being significantly lower in the pre-diabetics, suggesting that they cannot compensate. So if we look at plots, and this relationship has been well described already, insulin secretion versus insulin sensitivity, people who are obese, they may not be very insulin sensitive, right? But they are still able to compensate and make more insulin. And that's why in the early stages of diabetes, like pre-diabetes, it's thought that there is hyperinsulinemia. There's more insulin, as I showed you earlier, high levels of insulin to compensate. That's what we typically expect. In lean people, they may be very insulin sensitive and they may not need to make so much insulin. Okay? Now, as you become pre-diabetic or have type 2 diabetes, we know that these curves, if we were to plot them, it would be the same shape, but it just keeps moving down and down, but it would be the same shape. Okay? In our population, granted this is still preliminary findings, we haven't completed all 2,300, but if we plot them out, what you see is that even in our normals, our curve may not be so steep, but our pre-diabetics, it's not just that it's like that, it's more like it's flatter. Okay, so we can't seem to make enough insulin in response to a glucose load. So this paradigm that we have at the moment, does it hold true in our population? Doesn't seem so, in that essentially, this is very much shifted to the left, such that even in the pre-diabetes phase, we're already seeing this drop in the insulin occur. Okay? And so in individuals, we say here, these findings were presented at the American Diabetes Association in June of this year. And because at the time also we had more Chinese, we didn't want to jump the conclusion that, oh, Asians are like this, because we may not all be the same. So we said East Asians, because predominantly it was the Chinese, have a absolute their absolute insulin secretion in response to a glucose load is diminished, and there is lack of the ability of the beta cell of the pancreas to compensate to the prevailing decrease in insulin sensitivity in this population. So what are the implications? If it holds true, there are quite a few implications. One, the drugs that we use currently to treat type 2 diabetes, these are what our guidelines say. And this is indeed a frustration I have with diabetes. Whilst it's so encouraging that in this day and age, I practice medicine in an era where we have so many options for patients with diabetes. But we don't seem to be any wiser as to who should get which one. And the guidelines say, for the most part, everyone gets metformin to begin with. And then after that, if it's not well controlled, then you can do this, or this, or this, or this, or this, or this. And what guidance do you have to know what to pick? You're just the best you can, advantages and disadvantages, cost, how they work, their side effects, weight gain, low sugars, and so on, and you pick it. Okay? So yeah, we have some things, but I would say not very sophisticated beyond just understanding what the drugs do. We don't understand enough about how the patients respond and how they may respond differently. I would say it's somewhat analogous to cancer. When we had the older generation of chemotherapies, where you got so many side effects because you're just hitting it with a blunt sledgehammer. Yeah, it'll kill cells and it'll kill the cancer cells, but you also kill a lot of normal cells, right? And we were none the wiser. But now in the age where you have molecular genetics and you can actually do marker profiling and figure out whether the tumor responds to targeted immunotherapy. We're in a different era for cancer. And I'll argue that diabetes also needs to move in that direction in an analogous fashion, even though perhaps the underlying biology is completely different. And it may not be immune markers, it may be other markers, right? But that's what we're hoping to contribute through efforts like App2D. What are some of these differing markers that can help us tease out who might better respond to different things? Now, metformin, I just told you, is the most commonly used drug in type 2 diabetes, not type 1, right? Type 1 diabetes is when you don't make an insulin, so in that, insulin is treatment. But in type 2, everyone gets metformin because metformin is an insulin sensitizer. It sensitizes your body to the action, so it makes your door open more easily and respond better to the keys. And because we know that that is the first effect that occurs, everyone gets that first, okay? But if what I just showed you in our population holds true, then it's not to say that it will not work in our population at all, but we should not be surprised that it may not work as well, or not everyone might respond the same way. And perhaps therapies that target the pancreas and insulin would be a lot more efficient and effective in our population. So that's immediately one potential implication. But of course, to prove that, this study alone would not prove that. It would take then following up those people, say, who develop type 2 diabetes, and let's say we know who are the ones that have more of a key problem versus a door type problem, and then we randomize them to the different therapies and assess their response to the therapies. That would be the definitive way of proving what I just described, right? But drugs aside, what about foods? Okay, so although I did pharmacology as my first degree, my basic degree, I'm a huge proponent for lifestyle and whatever modifications you make in the lifestyle being the first line in any case, and it will help whatever stage of diabetes you're at, even more so when you're early, okay? So everyone says eat healthy, but it's so confusing. What does that mean? High carb, high fat. I was just at the European Diabetes Conference, and there was a session on dietary choices, and there was an abstract and oral presentation on high salt versus another one on protein, another one on carbs, and everything seemed to be associated with worsening diabetes. So what do we eat, right? There is the concept though that this is quite established. Complex carbohydrates, simple carbohydrates. It's almost virtually impossible to eliminate carbohydrates completely from your diet. Even if you eat vegetables and you think there's no carbs, there's still carbs. It's just how much, right? So complex carbohydrates, they take longer to break down and release the sugars. So the effect that it will have on your blood sugar in your bloodstream is more like this, if this is a graph of blood sugar over time versus time. Whereas something that gets broken down very quickly, the simple carbohydrates, they digest really quickly and then they will cause these spikes, right? So if you're a normal person, this still happens, but I just told you that normal is between 4 to 8. So this may happen, but you will still keep it within normal. But if you have a problem already with your door being too tight or you can't make enough insulin, then sometimes it may cross above normal, right? Now, so the concept then is that perhaps if indeed we have more of a problem with ability to make the insulin, then all the more we want to not stress our pancreas out and choose to eat foods that are like this rather than like this. Because if you keep eating foods like this, even if you have a healthy pancreas, you're just stressing it out to work hard, keep pumping out those keys. And insulin is an anabolic hormone. So even if you're normal, if you were to eat that and your insulin levels come up, you might find that before your next meal, you feel really hungry. And you feel this like mood swings and all, because that may be in part just a response to normal hormonal regulation and responses that are occurring to your types of food that you're eating. And if you don't believe me, you think, oh, that sounds possible, but that's, I don't know, right? Normal. Let me show you this. I was stunned myself when I saw this. He gave me permission to share this with you. He's actually a member of my RHS administrative team. And we're developing another proposal that I'll share with you a little bit more about later that incorporates glucose monitoring. So it's flash glucose monitoring. I'll show you the picture in a minute, but you've got a little patch that you wear here, and it's basically measuring your glucose every 15 minutes, and you don't have to keep pricking yourself, and you just tap and you look. And so they're all normal, okay? These guys in my office, probably like a lot of you here, fit, young, totally normal, active, skinny, right? So there were a couple of them who, because we're developing this proposal, wore it, and they're trying to get the experience, etc. So then we have this WhatsApp group, and they would be like sharing their experience, what's happening. And so he sent his profile to the group. I have his permission to share it. I asked him first before I put this up here. And I said, hey, what did you eat for dinner on Saturday? And what did you eat for lunch on Sunday? And he said, oh, I went to a wedding dinner on Saturday. And on Sunday, there was some really good homemade desserts at home. Why did you ask? I said, look at your sugars. He's totally normal. And this is normal. So you may say, oh, I told you 8.5, is that abnormal? No, because there's probably some degree of still, variability within that. So I wouldn't freak out. I don't think he's diabetic at all. He's probably not even diabetic. But that just shows you that in that spectrum that we talk about, it's real. Everyone's somewhere along that spectrum. In contrast, I don't have his law. I had another guy whose numbers were like red below 3.9, it will show red because it means that it's low and it thinks that it's dangerously low. His was like red throughout, and he freaked out. He's like, I feel fine. I said, don't worry, I think it's just underestimating a little bit. And actually, we always say 4, 3.9, but they are young, fit guys who run at low trees, and it's still normal for them. Okay, so so within the spectrum of normal, there's a wide spectrum, and it's really fascinating. It's not theory, it's really happening, and it's really occurring. So I wanted to make this point. While doctors, you think, always want to prescribe drugs, actually we know that lifestyle modification for a disease like diabetes can be more effective than drugs. There are non-modifiable risk factors. Your age, you can't change that. Your family history, you can't change that. Your ethnicity, you can't change that. And your genetics, you can't change, right? But there are plenty of things that you can change. Don't smoke, be more active, avoid certain types of foods if you can, and then certain types of foods are better than others. Now, we know that 40% of premature deaths are due to behavioral causes. So this is no joke. You talk about genetics, social, environmental, healthcare, surely they do more. Actually, the biggest cause is still behavioral patterns. So we also know from a landmark study way back 15 years ago that looked at people who were pre-diabetic, and they either got standard of care, like I just tell you, eat healthy, do the usual standard of care, versus metformin, the drug. So even though they're pre-diabetes, they put them on a drug, versus diet and exercise through an intensive program. They had like a whole SWAT team, physiotherapists, nutritionists, etc., aiming for 5 to 7% reduction in body weight, and you have to exercise at least 30 minutes a day and 150 minutes per week. So it's tough. Okay. So what did they show? Diet and exercise better than drugs, trumps drugs. So we know that lifestyle modifications can be more effective than drugs to reduce the progression of type 2 diabetes. So why aren't we practicing that? Why aren't we just doing it? Because it's damn hard, right? And like, to have the SWAT team is expensive. Not everybody wants it. Not everybody can afford it. And you can argue, and I think definitely some truth in that there's a selection bias inherently in people who participate in such studies. They're probably already more motivated to begin with. So how do you apply that to the average person like us, right? So I see that as a huge gap, and there are numerous programs right now in Singapore, the war against diabetes, that are rolling out. So that previous study is a landmark study. It's called DPP, Diabetes Prevention Program. So you'll hear DPP being quoted a lot. You're going to see already there are a lot of DPP programs now being rolled out in Singapore. Every cluster is rolling out a DPP program on the basis that, hey, we thought we knew it worked, right? So they're trying to organize the CCs, they're trying to organize whatever, which is great, okay? But in my mind, that study was done in 2002. We know it works. If we show it in our population, great for some people, for the people who manage to do it. But what about the rest of us? I don't think I could do it. And we are in 2017. We have technology. Why don't we leverage on that to do what DPP essentially was trying to achieve through physical activity and food, but leverage on technology? And I also found that my observation was that people who wore the CGM, because you are more informed of what your sugars are, your own data is a very powerful driver of your behavior. So it was based on these observations that I drove the team towards coming up with this proposal called TENDR, Technology-Enabled Diabetes Reduction. And I just highlighted to you where the gaps are, and we envisioned that the solution could be a technology-enabled lifestyle therapeutics, an application that integrates your diagnostic reports, health coaching, and real-time bespoke recommendations to match behaviors. I think the other, and I come back to again, like why we do research. We do research ultimately because we want the outcomes from our research to benefit our patients. And so oftentimes I'm really scared of having new ideas because it's a lot of work, and work like this is not one person work. You know, I will have to drag a whole people who are crazy enough and see the value in it to want to do it. Some of them are sitting here, right? So I'm almost really scared of having ideas that we don't have the bandwidth to follow through. And I've had this idea for a long time, but there was just either no bandwidth or I think not yet a confluence of factors that have maybe enabled us to do it. Now, what changed? Well, I think with CGM now being available more readily and seeing what impact that has, I think we are now ready to begin to embark on an adventure like this. The other motivation was that now we do have patients from AppToD who are newly diagnosed diabetics. And whilst we have other doctors on the team who call them and talk to them, I've also called and talked to some of them. And a lot of them, when they hear about it, they may be not very happy. And actually, I try and explain to them, actually, it's not so dramatically different, you know, when you know that spectrum, you just hear it's almost a technical definition now. But unfortunately, in the study, we have to follow the protocol, and that's the ends. But I would really suggest that actually now you may not even need medication because you're right at that cusp. You may not even need drugs. So between yesterday and today, me calling you, nothing has dramatically changed, actually. But it's a technical definition now, but it doesn't change that you ought to do something about it. And lifestyle is always, first and foremost, helpful. But then I have nothing else to offer them. And they're like, so you got nothing to offer me now? Like, what can you do? I said, well, yeah, you know, you can see a doctor. I said, yeah. But, so we give them all the standard information. And yes, it's standard of care. But there was also another PhD student in School of Public Health, and I'm on her thesis advisory committee, and she's doing a more qualitative sort of study on patient experiences, different spectrums of diabetes, and so on. So she was looking for patients with diabetes across the spectrum, including those who are newly diagnosed, and what their journey and experience is. So I said, okay, yeah, you can reach out to some of them, see if they would be willing to participate. And she only reached out to 3, but so yes, granted, it's a very small sample size, so there may be again biases, but none of the 3 followed up with a doctor. None. They all said, I guess I can deal with it. So are you doing anything for me? No, don't know what else to do. I guess, you know, I try sometimes, but that's that. So I guess again, the next step of research is always about, you know, just not being satisfied with the status quo and then figuring out what can we do next to try and meet some of these gaps. So we thought that initially we would target the newly diagnosed diabetes so that at least the people who come through AppToD, develop diabetes, we have something more concrete to offer them as well. And there's a whole universe of patients out there too who fit in this category, who are not part of AppToD, that we think we would partner with the polyclinics and the primary care providers, so they would probably be in that sphere to offer this to them as well. And what we would do is put them on the continuous glucose monitoring for 2 weeks, so we actually monitor what your glucoses are. And then we tender you, meaning we give you the app. It's an integrated dashboard with your sugar profile, and we're going to layer on, work with HPB. They have a Healthy 365 app. We've outline the specs and requirements that we think are needed to enhance the user experience for it to be more useful. And we want to layer on your food and physical activity onto that same dashboard. So that now, that profile I showed you, if that was you, you don't need to WhatsApp me and me tell you, hey, what did you eat? You say, whoa, I see. This is the correlation. And in future, I may want to alter my choices accordingly. Like if I eat 2 prata versus 2 chapati, I get a different pattern. I may say, hey, next time, even if I like prata, I'll do 1 prata and 1 chapati so I don't get this spike. And I think that self kind of knowledge about your own self, and I think also all of us may respond slightly differently to different foods and different type of physical activity. So what better way than to see for yourself how the different variants affect your parameters and what you can do about it. So that's essentially what we are looking to do. And the outcomes that we're after is to increase the ability to adhere to better lifestyle choices and reduce reliance on expensive, scarce manpower. Physiotherapists, dietitians, they are extremely rare species in the hospital. We really, really are short of them. It's tough, okay? So we can't rely on these type of professional workforce to continue to deliver these interventions. And overall, we hope also to demonstrate in this group, I think there is a decent chance that we can reverse their type 2 diabetes. So that's what we would aim to show. And I think if we can show that, then I hope that will also send a very positive message out to people that don't belittle the impact of your food choices and your physical activity, because it can really even reverse diabetes. So there'll be different components. I realize the time is late, so I won't bore you with them. But essentially, food choices, physical activity, integrate with the continuous glucose monitoring. In phase 1, that's what we'll do. In phase 2, we'll partner with others to layer on artificial intelligence. Artificial intelligence can only be developed when you have data. Otherwise, you have no intelligence. So once we roll this out, we will be collecting that data, and we want to then, the end product that I envision is that if you showed up at a Starbucks, you would then, people do Instagram feeds or photos, whatever, it would already, so let me backtrack one. When you start using the app, it will take certain parameters, your weight, your height, what are your goals? Are you diabetic, non-diabetic? If you're not diabetic, but your goal is just to eat healthier, to maybe lose 1 kilogram, these are my goals. Then you can say, okay, the app will tell you, right, I want to keep the food choices stuff very simple. Just either thumbs up, neutral or down, or red light, green light, orange light, where you then have an unlimited budget of green light, certain number of orange light, and only 5 red lights. So nothing is off limits, but you have to budget. So then when you get to your Starbucks, they'll say, oh, you want to order caramel macchiato, that's 1 red light budget used for the day. You might then change, and then you see, all these Instagram feeds, not bad, they have this new variant of a skinny cappuccino that looks pretty good, and that is an orange, maybe I'll do that. Better yet, you'll look at your calendar already, and if you set your alarm clock to 6 a.m., it'll say, whoa, your assistant just scheduled extra 2 hours, you actually don't have that window anymore to go to the gym or whatever, so you have to wake up half an hour earlier to get your steps in. Or you may want to consider, this meeting is at level 10, take the lift now to level 8, and it will prompt you to do that so that you can get your 2 flights and increase your steps and hit your goal for the day. So you almost have like a personal coach with you all the time, giving you hopefully relevant information that actually helps you shape your behaviors and achieve your goals. Last but not least, actually 2 more, which is gamification and incentives. I don't play Pokemon Go myself, but my whole family is crazy about Pokemon Go. We can be eating dinner and then suddenly I look up and I'm the only one left. They've disappeared because there's some rare something popped up and they're off. Right? And I don't get it, but there's something in it for some people. There's certain psychology to saying, hey, it's an image, and you get I don't know what it is, bragging rights or a thrill from seeing something grow. I don't know. And I've got other people in other generations in the 50s who say, hey, so I want to work with you. Have you developed like a Tamagotchi? I'm like, what's a Tamagotchi? So some creature I think that you feed and grow, and then you say Tamagotchi or something. Yeah. So, I mean, I think there's elements in that we can incorporate that doesn't rely on expensive financial incentives, but leverages on your social networks and your behavior. Even Facebook groups, Strava, how can you incorporate and leverage on your networks, family units, friends, to have that encouragement to maintain positive behavior change. Then last but not least, dream, up to D. Once we've had all the biomarkers and we know who's what better, if we can integrate that to this app and factor that in as another variable. You may be someone who does well with certain types of carbs, but not others. We can tell from the microbiome in your stool, for example, right? And so then whatever advice is given to you is actually more tailored to you. So that's the vision, and of course this doesn't all happen at once, it'll happen in phases. So I hope I've shared with you how research, you probably heard the buzz phrase translational research, and that's traditionally taken to mean translating bench research that's done in the lab, to bedside clinical applications. And then obviously, a lot of people have asked me, like, you're a clinician scientist, why do you do so much admin work? That's a waste of time, blah, blah, blah. Again, I didn't plan to do it, I didn't mean to do it. It always comes from frustration. When I'm discharging a patient from hospital, I worry about what's going to happen to them when they go home, and they may be just fine, or they might run into trouble, because I know that there's so many things that's just right now, and there's no reason to keep them in hospital, but who's going to keep an eye on them, and who can we handhold in the community to see them through? So that's really why I ended up doing a lot of things out in the community, finding good partners to work with, so that within our regional health system, we can build a stronger ecosystem to better meet the needs of our residents, from healthy, preventing complications right up to end of life. Now, that means that the needs that I see sometimes span from here to here to here, and it's never that neat. So it can go in different directions. And I'm someone who's a bit of a perfectionist, and I've often struggled that if you want to do something, you've got to focus. I always tell my team, don't just work hard, you've got to work smart, and you've got to be focused, you've got to know what you're after. And you've got to try and stay focused to achieve it, because otherwise, you spread yourself so thin, then nothing works. So I've often struggled with that tension as well, and then what my role really is, because throughout my career in research, I did this, I knew I never wanted to just do this, and this drives this, and then I end up here, and I'm so, this is what's going on, like, you're not focused, right? But I think now I'm completely at peace. I'm very clear why I do research. It's to find solutions and to help close certain gaps and overcome certain challenges. So I see my role and the role of our research program now really to be like a bridge, right? And this is the Helix Bridge near Marina Bay Sands. And a bridge isn't just our conventional bridge. It's not just necessarily even linear. This is the helical bridge. So it's not even a straight line. It may go in a number of different directions, but we're always very clear what destination we're trying to get to. So changing the course of diabetes is a huge team effort. And while I share with you data and updates and things, it's not mine. It's really a huge team of people who've been involved, some of whom are sitting here, who spend many tireless hours after working hours and weekends. And of course, a big thanks to all our participants. I mean, this HDB block, right, who come forward to take part in a study like this too. We have numerous co-investigators and collaborators, from basic scientists to School of Public Health, to A-STAR institutes, to Duke and NUS, and I'm sure actually a growing list that I haven't even managed to update. Of course, I also like to acknowledge our funders, the National Medical Research Council, and Janssen, who actually chipped in quite a significant amount of funding support towards App2D as well. And if you're interested to find out more on the study or to take part, these are the criteria, and we're also here to take any questions that you might have. I think I'll stop there, probably gone over time, but if you have any questions, I'll be around for a bit. Feel free to ask. Thanks for your attention.